Hello, and a very warm welcome to this VIA medical webinar titled High-Frequency Oscillatory Ventilation for the Treatment of Severe Respiratory Distress in Neonates. We're delighted to have you join us today. I'm pleased to inform you that the full live webinar is eligible for 1 contact hour of CRCE accreditation with the American Association of Respiratory Care, and please expect to receive an email from VIA with a link to the post-webinar survey. We are honored to have Professor Sherry Courtney join us as our speaker for the webinar today. Following her presentation, we will have the opportunity for a short Q&A. So if you have any questions throughout the webinar, please feel free to pop them in the Q&A box and we will address those at the end. So without further ado, I would like to hand over to Professor Courtney. Thank you so much.
Hi, everyone. Thanks for joining. I always love to talk about high frequency. And as I was kind of thinking back on how I got into this whole field anyway, I want to share a little story with you because I think it's kind of cute. And that is that back in the day, we didn't have surfactant, we didn't have any form of high frequency at all, but we had a lot of BPD, and we still have a lot, but for different reasons. And I was a junior attending just out of fellowship, and I came across this article in, I think it was a Journal of Pediatrics, and it was a case series of treating PIE, because we had a lot of PIE and really no way to treat it. And we had ventilators, but we didn't have oscillators or jets or surfactant or anything. What they did was they had their residents ventilate these babies with PIE at very fast rates and very small tidal volumes in 4-hour shifts. So you guys that are fellows or residents or respiratory therapists, be very grateful that that's not what we're still doing. So these people for 24 to 48 hours in 4-hour shifts were ventilating these kids very, very rapidly with bag and mask or bag and endotracheal tube. And it worked. And that just fascinated me. I just thought that was the coolest thing, that these very fast rates would do that. And I was in Dayton, Ohio at the time, and Wright State University. So any of you out there from Dayton or Wright State, hey. And I did it at my hospital for a while. The residents could volunteer. I didn't force them to do this, and it worked on some of our babies. So I got interested and started working in one of the physiology labs at Wright State with a couple of fantastic physiologists that were there at the time. We played around with a prototype of the jet. And then, interestingly enough, Gould Electronics, which is a company that's no longer in business, was in Dayton, Ohio, and they had a prototype of the oscillator. And we went over and we saw that, and we were just fascinated by that. And they let us have one in the lab. And then Sensormedics bought that company, and the rest is history. So that's kind of how I got into this whole thing of high frequency ventilation, which I've stayed in for many, many years in terms of clinical trials and research. So anyway, if anybody wants to handbag a kid for 4 hours straight, that's why I have such strong hands, because I did that, and I also did transport when we had no ventilators on the transports. So I'm going to share now, and no, that's not the right slide. I'll tell you about that in a minute. So, okay, I know I have to do something here to make it there. All right, hopefully that's the correct view, and if not, I'm sure I'll be told differently. So now I'm in Arkansas, and you might be wondering, how did you get in Arkansas? And what on earth is in Arkansas anyway? That's kind of what I thought. In fact, it was the Sensormedics guys, whoever they were called at the time, because the company has changed hands so many times. But they invited me to give a talk on oscillation in Little Rock. And I remember saying to myself, where on earth is that? And I kind of had the thought in my mind that it was probably just fields and deer and hillbillies, and I kind of had the picture of maybe this was the children's hospital and this was the transport vehicle. But no, it's not like that at all. In fact, it's just an incredible place, one of these little places that you don't hear anything about, and it turns out to be something marvelous. So this is our medical center, which has a respiratory therapy school and medical school and all kinds of schools. And then we also have the only maternal fetal medicine program in the state. So we have a huge catchment area, and we have a NICU here, but then we also have a children's hospital. And I really kind of like this this picture there. I like the helicopter in the background. The children's hospital is 330 some beds, and 104 of those are NICU beds. So we see pretty much everything. We have a 24-hour transport service, and it's really a very amazing place. So if you're ever in the area, come by and I'll give you a tour. Okay, let's talk a little bit about high frequency. Now, the Sensormedics 3100A and B have really been the workhorses of oscillatory ventilation for over 30 years. And certainly that continues to be true in this country. Over that 30-year period, because it was approved in 1990. In fact, it was approved the same year that surfactant was approved. So that was quite the year. Oscillation and surfactant both were approved in 1990. I could spend hours, but don't worry, I won't. This is, I'm sure, the briefest history of HFOV ever put on a slide. But I think it's important not to go over all those early studies. They were long ago, most of them. And I really think the only thing that you need to know is they were mixed. Part of the reason they were mixed in terms of their results is that they were all a little different. And that's a problem with clinical trials, is that, everybody puts their trial together a little differently, and the meta-analyses have to deal with that. So after 20 years, in 2010, a meta-analysis was done. It was an individual patient meta-analysis, which is a different way of doing a meta-analysis, looking at the patients rather than the whole study or the whole site. And the results were pretty similar. Not a lot of significant differences, benefits between HFOV and conventional ventilation. This meta-analysis was done on babies with RDS, which is what everybody was looking at back then, was the effect of oscillation on RDS. So these people, Philip Gools and co-authors, did another meta-analysis in 2015, which is really the most recent complete meta-analysis that there is out there right now. And they looked a little more broadly. They looked at babies with severe respiratory insufficiency, not just RDS, which is kind of what I'm going to be talking about today, is a kind of a broader application, because with the onset of surfactant, we don't see as many babies that have the severe RDS that are not responding to surfactant. So anyway, this meta-analysis found a small reduction in BPD, death or BPD, and severe ROP with high frequency. And I'm not going to show you the forest plots because, for one thing, you couldn't read them. They're too small. But I am going to show you just some of the results in print big enough that you can actually see it. So from this meta-analysis, which looked at HFOV versus CV for acute pulmonary dysfunction and not just RDS, if you compare the two and look at chronic lung disease at 36 to 37 weeks, or to discharge in the survivors, this includes 17 trials from 1992 to 2014. And there really haven't been any trials after that date. And that's 10 years ago. So things have changed, and we'll talk a little bit about that. There were a whole bunch of infants, almost 3,000 infants, and the relative risk with the 95% confidence interval was significant for a decrease in chronic lung disease, with a confidence interval not crossing 1. So that is significant. So there is an apparent value for using oscillation in some of these kids with acute pulmonary dysfunction that I think we need to keep in mind. And that's a different population than back in the 1990s and the early 2000s. They also looked at, come on, let's do this. They also looked at IVH. Now, IVH has been a bugaboo for years. And I really hope that we've put this to rest now, because the earliest study, which was called the Hi-Fi study and was published in 1989, showed a higher incidence of IVH in kids on oscillation, as did another study looking at the jet ventilator not too long after that. But it seems quite apparent that both of these increases in IVH occurred because of other things. The machines were not managed the way we manage them today. A lot of hypocarbia, not a good mean airway pressure approach to treatment of these infants. So I'm very pleased that both the 2010 and the 2015 meta-analysis showed there is no difference in IVH. You still see this quoted in articles and so forth. But in this one, which included even the 1989 trial and went through the latest trial by Sun in 2014, there was over 4,000 infants. And even including that other trial, you still see that the confidence interval clearly includes 1, that there's no difference in the incidence of severe IVH if you're using oscillation. Of course, you have to use it correctly. And of course, some of these trials maybe did not use it correctly, but even including all those trials, it's still not significant. So I think that's very important, that we not say, oh, we can't use the oscillator because it's going to cause bleeding in the head. And that really, I think, should be put to rest now. It's just not, it's not something that is true. And air leak is controversial as to whether or not the oscillator may cause a little bit more air leak, but at least in this meta-analysis, that was not the case. And this includes looking at gross pulmonary air leak. So you're talking about pneumothorax predominantly, or pneumomediastinum, or pneumopericardium, those kinds of big air leaks. If you include PIE, or if you look at PIE separately, there's a slightly increased risk with high frequency, which I question, because having looked at x-rays for many, many years, trying to say whether or not a kid has PIE or not, if those x-rays weren't, and many of them weren't, looked at by consistently by radiologists, then you just don't know. PIE is just really hard to define accurately. But at least in terms of the major air leaks, again, the confidence interval crosses 1, so not significant. And I think finally, retinopathy of prematurity, interestingly, as far as I know, no one has any idea why this might be, something to postulate, but retinopathy of prematurity was actually decreased in this latest meta-analysis with a confidence interval below 1 in favor of high frequency. So there seems to be a small effect in favor of high frequency on BPD, and a little bit bigger effect on ROP, and no difference in IVH, and no difference in air leak. So I think there are some good reasons to use high frequency, but like I said, they're not the same reasons that we had many years ago, and we'll talk a little bit about that. Now, this is a forest plot, but don't try to read it unless, I guess it's easier these days because everybody's in front of their computer. If you're sitting at the back of a big conference room, it's like, come on, this is impossible. But because it's got a lot of stuff on it, I'm just going to go over the basic results here. Let me see if I can move that somewhere. So they looked at this. Actually, this is a really good article. This is Ackerman. And if you want a good article to kind of review the status of high frequency, I can't remember if these were sent out to you, but this one is in Pediatric Research this year. So this is about as good as you can get. And they did look at several things. They divided them into high frequency versus low rate conventional mechanical ventilation, meaning below 60, and then high rate. And you can use these ventilators at higher rates, but there's a lot of problems that can occur with that. So most people don't do that anymore. And look at, these are older articles, and as I've said, none of them are past 2014. But the bottom line here is that if you look at the sort of general conventional mechanical ventilation, and you divide it into the articles that used that and didn't look at the other articles, it's significant. This little point is considerably to the left of the line, meaning it's significantly in favor of high frequency oscillation. Now, when you start with the higher ones, and you're looking at, in this particular forest plot, they looked at BPD in preemies with RDS. So this went back to the RDS of previously. If you look at the higher rates, there really was no difference. And this is older articles, and I don't think people are using high rate conventional ventilation much anymore, because we do have options now. We have the jet, we have the oscillator, and we know that inadvertent PEEP is a common problem with high rate conventional ventilation, and it's really not it's not optimal. And if you need higher rates above 60, you should probably go to some form of high frequency. Then they had a category called unclear ventilator strategies. They weren't quite sure what was done. And no surprise there, that was not significant either. But if you combine and look overall, there's still a favorable, very similar to the Cools meta-analysis. They just broke it out into different categories, which I think is kind of interesting to kind of see where the differences are in these meta-analyses. So anyway, this is a very good article, which I highly recommend that you read if you want to get some very current information on the state of the art. There's one more that I think might have been sent out to you that was published very, very recently as well by Hibbard, and it's in Archives of Diseases of Children, the Fetal and Neonatal edition. But you guys might have gotten that from the Via folks. Seems to me one of the flyers had these 2 articles on it, and I do highly recommend them. They're not too long and they're very current in terms of the state, kind of the state of the art. So that's all pretty good news, though it does have articles that don't go beyond 2014. So important points I want to make about all that. The last comparative study was Sun's trial in 2014, 10 years ago. I don't think we're going to see another one happen. I wouldn't put your money on it, but I think it's highly unlikely. These kinds of large ventilator trials are very difficult to do, and I know because I did one, and they're also incredibly expensive. If there's some new hot off the press thing that looks awesome, and oscillation did back many years ago, and that's why there were trials to try and figure out what it gave in terms of a benefit. But today we're just not as interested in that. We have surfactant, we have other means of dealing with severe pulmonary disease. We have ECMO, we have the jet, we have the oscillator, and as I think all of you know, we are much more interested in non-invasive modes of supporting the baby with RDS or other severe respiratory dysfunction. That's where right now we're focused in terms of large trials, and even those are not very common because of the expense and difficulty of doing them. But they're more common than these ventilator trials. So non-invasive ventilation, different kinds of non-invasive ventilation, that is where a lot of the trials are now focused. But as I have mentioned, oscillation is still very useful, but its uses have shifted, as has the way that it is provided. So the Sensormedics is still the only oscillator that is approved in the United States, and there are lots of reasons for that. Companies are waiting to get newer ventilators on the market. They have to get through the FDA, and I find it very frustrating because these newer oscillator modules are and have been available in Canada and Europe for years now. We at our institution were part of a trial looking at this particular one, which happens to be the Draeger module. It was just incredibly quiet. You couldn't even tell the machine was running when you walked into the room, and that's a problem with the Sensormedics, and it is very very noisy, and that may have an effect on babies. These newer modules can be just slipped in and out of the ventilator, so you don't have to go switching ventilators and dragging cords all over the place and tripping and bagging babies while we're switching to another ventilator, which is maybe one of the biggest reasons to go to these new modules. They also provide some new information, which is very, very useful, and that is it can provide volume targeted ventilation, which we all know now is incredibly useful and is the way we ought to be ventilating all babies, not with pressure limited ventilation that doesn't change your tidal volume or lower your pressure to keep your tidal volume the same. And it has something called DCO2 monitoring, which is diffusion coefficient of CO2. And that can be very helpful in terms of trending the CO2, because CO2 is it's so important that we not let these machines overventilate in terms of the lung, but also overventilate in terms of the hypocarbia that can occur and damage the brain significantly. This is another one. I really like the screen on this one. This is the Fabian, and it also provides your tidal volume. See here more clearly the DCO2, and gives you your loops and your breath to breath and so forth. Very very nice screen, and very quiet machine. So what is the problem? Why can't we get these kinds of changes put in place in the United States? You know, I'm very curious about that, because volume targeted ventilation has been shown in 3 meta-analyses now to decrease morbidity with conventional ventilation. Now, we don't know this for sure, though there are a couple of studies that suggest it and other work that's ongoing. But having volume targeted ventilation with oscillation will very likely produce similar results as volume targeted ventilation does with conventional ventilation. We know, and we've known for a long time, that volutrauma is more dangerous than barotrauma. And so having this available on oscillation is really, really important. And the diffusion coefficient of CO2 is equal to the frequency times the tidal volume squared. And we know that the tidal volume is more important with oscillation than the frequency per se. And so it can help us trend the CO2. So here's my personal thought on why these ventilators aren't available in the United States. The secret to happiness, I have found it, but the FDA won't let me release it. I may be wrong, but anybody that's dealt with the FDA knows that the process is long, torturous, and difficult. So I think that's at least one major reason why we don't have it yet. But it's coming. For those of you that are younger than I am, which is probably everybody, this is coming. And I'm very, very glad it's coming, because it will be so useful to us as we use high frequency ventilation. So I have to show one of the many, many slides on how high frequency works. And it's slightly different than the jet, which is another talk. And we see all kinds of things that are happening at the same time. All right, we have very turbulent flow in the upper airways. We do have some direct ventilation on alveoli that are close to the trachea and the major bronchi. We have all kinds of things called asymmetric velocity profiles and pendulift and turbulent flow and radial mixing and laminar flow and all kinds of things. There are some very good articles to describe all of these different ways that high frequency oscillation provides ventilation. And this particular one is kind of edited from Jane Pillow and Jeffrey Drazen's work, which was published in the New England Journal. Actually, it was the same article that our study and the Johnson study was published. So that was, my gosh, that was in 2002. So it's been a while. But the way that oscillation works hasn't changed. And it's important to realize that though all these things occur with conventional ventilation, they don't occur nearly as much as with oscillation, which allows the very effective ventilation that occurs with high frequency. One of the things that I think is difficult to remember is that the transmission of pressure is attenuated significantly with high frequency. When you set your amplitude of 20 or 30, that's not what's reaching the alveolus. Depending on the size of the endotracheal tube and the hertz, you're getting 70 to 90% attenuation. So On the other hand, when you're using conventional ventilation at a much slower rate, the pressure gets transmitted pretty much the same from the endotracheal tube down to the alveolus. I also like this slide because it shows the differences in pressure among conventional, high frequency, and jet. And the jet is a whole different animal and needs a lot of thought and education before the jet can be used appropriately. With the oscillator here in the middle, you see that the mean airway pressure stays pretty much the same. This isn't entirely true, but it's close enough that you can use it to think about the pressures. And if your amplitude is decreasing, your mean airway pressure stays pretty much the same. The mean airway pressure with the oscillator, as you probably were taught, it's like PEEP. The oscillator is just a big PEEP machine. In fact, you can actually oxygenate somebody pretty well if you just turn off the amplitude and use an appropriate mean airway pressure. Now, you won't ventilate worth a darn, but you can oxygenate. It's PEEP. And so we all need to be very careful about not getting PEEPophobic and using the appropriate mean airway pressure. With conventional ventilation, as I said, the pressures are staying pretty much the same. But with the jet, your mean airway pressure is not set like it is on the oscillator. So it's going to change depending on what you do with your PEEP and with your peak inspiratory pressure. Now, I cannot give a talk about oscillation without showing my St. Louis slide arch. I've used this slide to incredible advantage in many, many talks. And I often will ask people, where is this arch anyway? And I had one group once that decided it was in Egypt. So I suspect that those people were from the East Coast because they don't know anything about what goes on in the West. So I always say that this slide shows that this arch was put there for the single reason of reminding people that you have to have the appropriate mean airway pressure. Now, people argue about that. And they say it's the gateway to the West or something, but nah, I think it's all about mean airway pressure. By the way, if you've ever been up there, it's a pretty scary deal. If you look down, you can't see anything holding you up, but it's kind of fun. So if you're on the side of the St. Louis arch, all right, what is the lung doing? The lung is atelectatic. And you're going to have trouble ventilating and you're going to have trouble oxygenating. And if you're on this side of the St. Louis arch, then you're going to be overdistended and impeding venous return, higher risk of IVH, decreased cardiac output. So where you want to be with your pressure, this is pressure, all right? This is very low pressure. This is very high pressure. You want to be at the top of the St. Louis arch. It's not always easy to find that. It does happen to be easier with the oscillator than with other forms of ventilation. And your maximal benefit is going to be right here at the top if you can find it. Now, I believe Dr. Anton von Kamm gave a lecture on early use of high frequency not too long ago at one of these webinars and went over the pressure volume curve and how it is that you can get to an optimal point with the lowest pressure. If this is your change in pressure here and this is your change in volume, you know, you first have to open the lung, right? And then you get the lung pretty open and you're going to have a tidal volume that if this is your change in volume, you're going to have a tidal volume that's where you want it to be. But you're going to do it at a higher pressure cost of ventilation, which is a term you'll see in a lot of the literature. What you want to do is get to the descending limb of the pressure volume curve by going up a little bit and then coming down, all right, until you reach that point where you have the same tidal volume, but a much lower pressure. And this is what you can do with early onset high frequency. And Dr. Van Kam, I think, talked very nicely about how to do that. And it doesn't take that long. So if it's possible, we try and do it in our unit. I know Dr. Van Kam is extremely successful doing it in his unit, and it can lead to better outcomes if you're able to do this. So this is one of the ways to find your optimal pressure point. And go back and listen to his talk if you want. I'm not going to spend a lot of time on that because I think he did a wonderful job of explaining it to you in that webinar. All right, so what about the hertz? Well, I hate equations. This is frankly a simple one, but I show it to you only to tell you about the corner frequency, which is beyond that frequency, you don't get optimal use of your oscillator. And if you can look here, this is resistance, this is compliance, this is pi, and this is your corner frequency. So what does this say? This says that your optimal frequency is inversely related to your resistance and compliance. What is that? That's your time constant. For those respiratory therapists will know all about that. So I think this is very useful when you're thinking about what frequency to use on the oscillator, because if you have a high resistance disease like meconium aspiration, you will do better at a lower frequency. On the other hand, if you have a lower compliance disease like RDS, you will do better at a higher frequency. So it's important to set your frequency for the optimal treatment of the lung disease you have. One of the problems people have with using oscillators is changing the frequency all the time. And that's really not a good thing to do. You will get a better effect if you use a frequency that is more tailored and targeted towards the disease that you're trying to treat. And that's why I think this is really important. If you can just remember your frequency is inversely related to your resistance compliance, then you could say, oh yeah, I have high resistance, so I need a lower frequency. And it's important then to keep it there and not be changing it unless your lung disease is changing. In terms of your amplitude, if you have an optimal mean airway pressure and hertz, this will allow the lowest amplitude and therefore the lowest tidal volume. We've talked about how volume targeted oscillators will assist with this and provide your diffusion coefficient of CO2, which we said is the frequency times the tidal volume squared. Now, this is not an absolute number, all right? It's going to vary with the weight and disease process of the baby. And so it will serve as a guide for you to your CO2 diffusion, but it's not linearly correlated with your PCO2. So once you kind of figure out where your DCO2 is for your baby, that gives you your optimal CO2, you can kind of trend that and follow that. I think it's better, maybe not better, but certainly equally important to have a transcutaneous monitor on. There's a whole nother talk as to why we really can't use end-tidal CO2 in these babies. It's just not, it's not accurate. Most babies can tolerate a transcutaneous monitor extremely well. Even the tiniest babies. I don't know if you've tried putting it on the forehead, but that's a place that seems to be very useful in these little babies with their very thin skin. This is a idea of where your tidal volumes are with high frequency. This is an article that you might want to look up from a few years back. But here is your frequency, all right, and here is your tidal volume. Now, this is in mLs per kilo. And you can see that where we usually run our oscillator, which is going to be, in our babies, it's going to be like 10 to 15 hertz, and maybe down to 8 in our meconium aspiration kids, you're going to see that your tidal volumes tend to be in the 1.5 to 2 ml per kilo range. That's kind of a guide for you. It's going to vary somewhat, but we should be kind of looking for that, and then looking to make sure our gases are acceptable and our DCO2 is trending in the right direction. And that I know from using, some of you may be from Canada or Europe where you think, oh, this is old stuff. But for those of us in the United States, this is new. It will be coming, and it gives you an idea of where the tidal volume ought to be for babies on high frequency. So again, a transcutaneous monitor is very, very, very important. We tend to use them for all babies that are on either the jet or the oscillator, because CO2 can get out of hand so easily. And this is not only in the literature, but it's also in the public domain. I was recently asked to be an expert witness on a case where one of the reasons that the parents decided to sue was that this particular baby had a CO2 in the 20s for several hours. And we just can't be letting that happen. And we have means to prevent it these days. IE ratio, the Sensormedics appears to be the most effective at an IE ratio of 1 to 2, and there's very little data on its use at other IE ratios. When we transition from CV to HFOV, we usually put our map a little higher on the oscillator, and this is not because it works better at that map. It's because you're actually approximating the map on conventional. Due to the flow characteristics of the oscillator, you're pretty much giving the same map when you increase it a little bit on the when you're changing to the oscillator. Another thing to remember is that different oscillators at different IE ratios are not going to have similar transitions. So if you're using a Hummingbird, which is in Japan, they usually use that particular machine at a 1-to-1 IE ratio. You have to be very careful about what you're doing if you're using different machines or different IE ratios. So right now with the Sensormedics, we need to be probably using it at 1 to 2, unless you're doing some sort of research study. So all that said, where are we using high frequency today? We're using it predominantly in early onset ventilation for extremely low birth weight babies. They may or may not have RDS. And the reason we're using it in those babies is because we can set an optimal mean airway pressure. And following that, we can have the minimal, hopefully minimal lung disease that is possible when needing to use ventilation. We use it for severe homogeneous lung disease. And by homogeneous, I mean it looks pretty much the same on an X-ray. It may be pneumonia, it may be pulmonary edema, it may be severe RDS that hasn't responded. We use it for meconium aspiration with nitric oxide, for abdominal distension, and for pulmonary hypoplasia. So first intention use is sort of like, I keep thinking what goes around comes around, because this is where we started using it back in the day, but we didn't have surfactant at the very beginning, and it took several years for surfactant to be used throughout the NICUs in babies with RDS. But now, given the data on how we can set an optimal mean airway pressure, we are starting to use this in many NICUs in our very, very little babies. A lot of NICUs are resuscitating 22-weekers now. And the use of early onset high frequency is one of the cornerstones for treating these babies and minimizing the lung damage that they may have. You can also do early onset with the jet, but it's not been nearly as well studied. So I can't really give you settings or ways to use it. But if you think about it, it is another form of high frequency, and there would be very likely ways to use early onset jet and minimize lung damage as well. But that needs more study. Severe homogeneous lung disease. This is an example of I don't even know what's wrong with this baby. It looks like he may be on ECMO, so that's not a good thing. But the very hazy lung from any one of a variety of issues is a good place for the oscillator. The oscillator is not a good machine for significant non-homogeneous lung disease. And probably the best example of that is severe BPD. Those babies have areas of atelectasis and areas of overdistension. Remember that you're using a single mean airway pressure, and that mean airway pressure will either, depending on where you set it, treat those areas of atelectasis or treat the areas of overdistension. It will not treat both. That's a disease that is better addressed by the jet. I've seen a lot of people use the oscillator for that with pretty bad results. And if you think of the physiology, which is what you have to do in the lack of large trials for non-homogeneous lung disease, which is never going to happen, you can see that one machine is better than the other for that. But the oscillator is really effective for homogeneous lung disease. Meconium aspiration, and you say, well, it's kind of non-homogeneous, and you're absolutely right. But if you use a low hertz and you use it in the presence of nitric oxide, it seems to be better for meconium aspiration, but not all kids will respond well to it. So you have to give it a try and see whether you can manage meconium aspiration best in that way. And John Kinsella's study was the one that showed it seems to be better than conventional ventilation in the presence of nitric oxide for meconium aspiration. Abdominal distension, this is a perfect place to use the oscillator. Many of these kids have either normal lungs or lungs that are not severely sick. They may have just developed neck or sepsis or have some sort of anomaly, but having a mean airway pressure that's consistent to keep the lung open, this is really the best. I would go so far as to say you should not be using a conventional ventilator on a baby like this. You should be using an oscillator because it will keep the lung open and at a minimal tidal volume to try to not damage the lung while you're trying to treat what's going on in the abdomen. And lung hypoplasia, there are, somebody's NG tube is not in the right place. But other than that, I guess the best example I can give you is that if your kid is viable, it's true that lung hypoplasia in many of these kids, because of the kidneys, may not be viable. But if the baby is viable for whatever reason, you can treat. I kept a kid for 3 months on the oscillator. I remember very, very well while the lungs were growing. Whether in this day and age we could have kept that kid on non-invasive, I don't know, but I kind of doubt it. At any rate, if you need a ventilator and you do have lung hypoplasia and the baby could be viable, the oscillator is really the way to go for as long as it's necessary for those lungs to develop enough to be able to use non-invasive or extubate the baby. So where high frequency may not be the best choice, clearly in today's world, infants who may do well on non-invasive ventilation, infants with non-homogeneous lung disease, air leak, and diaphragmatic hernia Okay, next slide. Well, that's interesting. All right, let me try it this way. You know, you can't get through a talk without technical problems. Okay, so many infants are treated on non-invasive ventilation of one kind or the other, and that's fabulous. It looks like that's the way to really minimize lung damage. And whether you're using CPAP or NIPPV, which works in some cases, or NIV-NAVA, which is a fabulous choice for babies that can breathe. If it works, then that should be the way we're going. We should not be keeping babies intubated for long periods of time if we don't have to. This is a baby who should not be treated with HFOV. In fact, I don't know if this baby survived or not, but the best chance this baby would have, in my view, would be the jet, because of the way it works and the different things it can do. But I wouldn't, if you have the option of a jet, I wouldn't use the oscillator for this kind. It's not the way the oscillator is meant to work to treat this kind of disease. Air leak, you can treat air leak with the oscillator. The jet is usually better for this as well because of the way it works. So if you have that option, that may be more effective. And diaphragmatic hernia, there have been some small studies looking at the oscillator, and it does not seem to be very effective with diaphragmatic hernia, probably because you don't want to over distend any part of that lung, which is already not in very good shape. But we really don't know the best way to treat to ventilate these babies with diaphragmatic hernia. But right now, it does not appear that the oscillator is probably the best way to go with this. So the future for HFOV, I think that volume targeting and DCO2 are going to become very common, that we're going to see these ventilators very soon in the United States. And hopefully there'll be several of them that we can pick from. But this is the way it has to be in the future to use the oscillator optimally. Nasal HFOV, now there's an interesting topic. This has been studied some, and it may become commonplace, but we need more trials to figure out how useful it really is. And I think that the large patient trials, as I've said before, are going to become rare, and the clinician must understand the physiology of the disease being treated and the physics of the machine to provide the best outcome. That's just really important. If you don't know what your machine is doing and how best to use it, then you may not be effective in treating anything. So I've always liked this picture. I think it's very cool. And I will end with saying, whatever form of ventilation you use, know how to use it well, and you'll get the best possible outcomes that you can for that form of ventilation. So if you ever come to Little Rock, see how pretty a place it is? Look me up, and I'll be happy to give you a tour. And thank you very much for your attention.
Thank you so much, Professor Courtney, for that fantastic presentation. We've got a few minutes now for some questions, and some have already come through the Q&A, so I'll share those with you now. So the first question is, do you use RAM cannulas?
Somebody planted that question. The RAM cannula is not approved for CPAP. And so we do not use it for provision of CPAP, except in special cases where there may be some irritation of the nares and some bigger babies that don't easily take to the to the CPAP device. It's not approved, and you don't give the pressure that you may think you're giving. It's at least 2 to 3 centimeters less because of the leak, which needs to be at least 20% or more around the prongs. Remember that it's a cannula. It is not a CPAP device. It can be used in some cases. If you are trying to use consistent CPAP, you should use a real CPAP device.
Thank you. The next question is, what recent advancements or new research findings are there in the field of high-frequency oscillatory ventilation for managing severe respiratory distress?
Well, I think the answer is not a lot. I tried to go over what we use it for today. I think that the research on nasal high frequency is going to be very, very interesting. It kind of varies depending on what article you read. So I don't think we have the answer yet, but there are places that are using it almost exclusively. So I think that's an area that we really need to watch. I think using it for the appropriate disease is something we need to do now. That we used to use it for everything, and then, oh, this doesn't work. Well, it was probably either you were using it wrong or you're not treating the right disease, that you may need to use the jet, or maybe the baby can be extubated, which is wonderful if you can do that. Other than that, I'm not aware of a lot going on that's new and different. I do highly recommend those 2 articles. Chloe, did you send those 2 out to everybody? That was the Hibbard one and the Ackerman one. If not, maybe we could send them. You have them, I know, because you could send them out to the folks, because they're really good in terms of where are we now with high frequency.
Thank you. The next question is, why is high frequency not a good option for air leak?
Well, it's not necessarily not a good option. It's just that the jet may be a better option. The jet you can use the jet with an extremely long expiratory time. Remember, it's not an IE ratio. It's a set inspiratory time. And then you can use a very low rate with a very long expiratory time. And the way the pulse of gas comes down, what happens is that you have time for that air to get out, and it can be incredibly dramatic. With oscillator, you have to use the same mean airway pressure. So it's going to be that same pressure, and that's not the optimal way to get rid of air. On the other hand, if you're using a very low tidal volume, it might work. So I'm not saying don't ever use it. And if you don't have a jet, you should try it. You should try it at a relatively high rate with a low amplitude, and see if it works. But there are times when it won't, and that's when you need to perhaps use the jet.
That leads on to the next question. Another attendee has asked, how does the jet differ to the oscillator?
Well, number one, the jet has passive exhalation. All right, so the oscillator has a piston that goes back and forth, so you've got active exhalation. And because the tidal volumes are very small, that doesn't affect it doesn't pull the lung out of the endotracheal tube, okay, which used to be a thought back many, many years ago. The jet has passive exhalation, all right, so you have to use it at a slower rate, otherwise you'll get inadvertent PEEP. And it does have that set inspiratory time, which you can change under some circumstances, but only if you can't reach the pressure that you need with the inspiratory time that's set, which is 0.02 seconds. The only way you can get 0.02 seconds on the oscillator is at 15 hertz, which means that your expiratory time is really short. So with the jet, you can use a long expiratory time. And the other important thing about the jet is you can give side breaths, which makes it ideal for treating non-homogeneous lung disease. So you can set your mean airway pressure appropriately to maybe take care of the overdistension, and you can use a that's a cat. A little sigh rate, like 2 to 4 breaths per minute, to open up the atelectatic regions. Now, the newer oscillators can also provide those sighs, which is something I didn't mention. So it may be with some of these newer oscillators that you can treat some of these conditions more effectively.
Thank you. The next question, some avoid high frequency because of the inability for parents to hold their babies. Do you agree with that?
Well, it's harder, but it's absolutely not impossible. And it's easier with the jet because you have a very flexible tubing, but you can also do it with the oscillator. It kind of depends on the size of your NICU, how you do it. We have brought moms in on stretchers and then put the baby on their chest. And that's probably the safest way for them not to extubate. But you can also use kind of a higher chair and put the baby on the mom. I know how important it is to have that contact with the mother. On the other hand, if that oscillator is doing what it needs to do and preventing lung damage, that's really the most important thing at that moment. So our nursing staff can get really creative in terms of how to make that happen.
Great, thank you. Another question, do you use high frequency to treat pulmonary hemorrhage?
Yeah, it can be a good way to tamponade, just like you can use it for pulmonary edema. So, if you think about what you're trying to do, that's a good way to do it. You have that constant mean airway pressure, and it can, rather than the up and down of conventional ventilation. So yes, you can absolutely do that.
Great, thank you. How do you deal with babies who are hyperinflated with a high FiO2 requirement? Do you touch the mean airway pressure?
How do we deal with hyperinflation?
Yes, hyperinflation with a high FiO2 requirement. Do you touch the mean airway pressure?
Hyperinflation is a real difficult problem. In fact, the BPD collaboratives, I think they're going to be looking at that specifically in the near future. Yes, if you can, you want to decrease the mean airway pressure. A lot of it's going to depend on what else is going on in that lung. Do you have atelectatic areas as well? Because if you do, or even if it's just severe hyperinflation, it's probably got some areas of air leak, and the jet, again, may be a better option. It's hard to treat. It's really hard to treat.
Thank you. We have time for a few more questions. Do you extubate from high frequency?
Oh, thank you for that question. I think somebody planted that. I kind of didn't mention that because I was kind of running out of time, but the answer to that is yes, 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 and yes. The only situations where you may not want to do that are kids that for some reason are paralyzed. Clearly you can't extubate. Now that usually happens with older kids and adults, but think about what's happening. If that baby has a mean airway pressure that is similar to a PEEP that you would use on extubation, and an FiO2 that is fairly reasonable, like below 30% or thereabouts, and is ventilating himself or herself well, why would you want to switch to conventional ventilation? The whole reason you switched to oscillation was to avoid tidal ventilation and lung damage. So now that you've done that, hopefully, the best thing to do is extubate to some form of non-invasive. Now, my personal bias is that NIV-NAVA is the way to do that. there's a study going on right now that I'm part of to look at NIV-NAVA for extubation. So maybe we'll know more about that later, but NIPPV can work. I'm not sure how it works. It doesn't transmit pressure, but it does something. But yes, try non-invasive. Once you get that baby down to like maybe 8 centimeters median airway pressure, which will be 6-ish on your extubation, and a relatively low FiO2, get him off, and at least try it, and you'll find that most of the time it'll work.
Great, thank you so much. Well, that is all the time we have for questions. I just want to say a huge thank you for that fantastic presentation. We're honored to have you speak for us, and thank you so much to all of our attendees for joining, and I hope you have a great rest of your day.
Thanks, everyone.